I almost 10:01, so I need to get us started before our morning slips away. I'm having a great morning. I'm hoping everybody else is. It's my pleasure to introduce Dr. Brenna Maddox. She's going to be doing a presentation entitled Working Together to Improve Community Mental Health Services for Adults on the Autism Spectrum. And, you know, I've known Brenna, I don't know how many years actually now, Brenna, and it's what I find so remarkable is you're pretty young in your career, but you've already established yourself, I think, as a expert or someone with significant expertise in this area. That's an incredibly important area, which is working with autistic adults and mental health issues. So it's wonderful to be able to have invited you and to hear what it is that you have to say. And certainly I look forward to hearing about it, and also whatever collaborations we can get off the ground at some point. But let me do a little formal introduction. So is an assistant professor in the Department of Psychiatry at the University of North Carolina, Chapel Hill. As the implementation scientist for the Teach Autism program, her work focuses on improving community services for people on the autism spectrum across the lifespan. She's particularly interested in training and supporting community mental health clinicians, modifying cognitive behavior therapy for people with autism, with anxiety or depression, and preventing suicide in this population. Dr. Maddox is also a clinical psychologist with expertise in the assessment and treatment of co-occurring psychiatric conditions in autism. She's a deputy editor for the new journal Autism in Adulthood and is a co-chair of the American Association of Suicidology's Autism and Suicide Committee. So with that, I'm going to turn it over to Dr. Maddox again with applause. And I'm going to pop back in about 45 minutes to do a little Q&A. So Brenna, take it away.
Thank you so much, Judy. I am so excited to be here, and thank you for that kind introduction. Judy's work with the Facing Your Fears team has inspired a lot of my work, so it's extra special to be here. I am sad that we are not all in person. I love Denver. I love Colorado. I spent 3 summers in Boulder during my undergraduate years, and hopefully one day soon we can all be together again to talk about this important topic of mental health and autism. So let me make sure that I am sharing the correct slide here. I'm going to make sure you can see what you're supposed to be seeing. All right, so Judy, maybe you can pop back on and just tell me, are you seeing the correct slides? Not my notes?
Looks perfect.
Okay, thank you for confirming. Perfect. All right. So as Judy said, I'll be focusing today on how we can improve community mental health services for adults on the autism spectrum. And I look forward to having some time to discuss this topic with you all during the Q&A period. Before I jump into the presentation, I do want to make a few acknowledgements. A lot of my research is stakeholder engaged, meaning that I work closely with partners in the community, including adults on the spectrum, family members of individuals on the spectrum, and community clinicians. So I really do want to acknowledge them up front, because this work would not be possible without their partnership. I'll be presenting some results today from a few studies that have been funded by the NIMH and the FAR Fund. And then I've worked with an amazing research team. I'm very grateful for my mentors and my collaborators, only some of whom are listed up here. So what I'm hoping to accomplish today in 45 minutes is to describe the common co-occurring mental health conditions in autistic adults, moving on then to discussing barriers to autistic adults receiving quality mental health care. And then finally, what I would say is the most important part would be, how can we make improvements? What are some actionable strategies that we can take? And I know we have some wonderfully helpful interpreters here today who have advised me to speak slowly, so I will be doing my best to do that as well. And I also want to make a quick note about choice of language before we move on to the content of this presentation. So I'm not sure about everyone here today. I was trained in graduate school to use person-first language. when talking about individuals on the spectrum. So person first would be adult with autism or person with autism. And again, that's how I was trained, and that was my choice in language for many years. More recently, there have been some publications out, some editorials about, for many individuals on the spectrum, they prefer identity first language. And this would be saying autistic adult or autistic individual. And I mentioned my community partners a couple of slides ago. My community partners have expressed this preference for identity first language. So you'll just notice that throughout the presentation, I'll be referring to autistic adults. And if you are, like me, interested in learning more about the power of our language and how we can respect preferences, I don't think we can ever be 100% perfect or respect everyone's preferences, because I know that there is a wide range. But I really enjoyed this article that just came out in the journal that Judy just mentioned, Autism in Adulthood. It's called Avoiding Ableist Language, Suggestions for Autism Researchers. And I just wanted to highlight it here. I learned a lot from reading this article. I'm continuing to think about ways that I can modify my own language to avoid this ableist perspective. So if you're interested, feel free to check that out. It is open access, at least for now. All right. So I really enjoyed this last presentation, focusing on, I like the adjective of tumultuous time of adolescence. And before we move into talking about adults on the spectrum, I like to just pause and have everyone reflect on what autism means to you. So when you think about autism, what do you envision? And for many people, they think of a child. Now, after that excellent presentation, now you may actually be envisioning an adolescent on the spectrum, which is wonderful. But generally speaking, and I can say, when I meet someone in the community and I tell them what I do, more times than not, they say, oh, I know a kid with autism, or they start asking me about autism in children. And I think this is not surprising that many people think of autism as a childhood condition. However, we know autistic children grow up into autistic adults. And in the next decade, in fact, over 700,000 autistic teenagers will enter adulthood. So if you think about it, my postdoctoral mentor, Dr. David Mandel, made this point in an editorial that on average, autistic individuals will spend the majority of their lives as adults, similar to most individuals, the majority of them. So historically, adults on the spectrum have been largely ignored from research, but fortunately this is changing. So now we see things like entire books about autism and adulthood, as has been mentioned, journals focused on this important topic, resource guides, popular press articles, funding announcements for grant funding specific to adults. And as the last presentation also highlighted, even popular TV shows on Netflix, such as Love on the Spectrum. And with these research studies and partnerships with autistic adults, there's one thing that we've seen and heard about over and over again. And that is this issue of having co-occurring psychiatric conditions or mental health concerns. And I know from talking with Judy that this conference, the focus of this conference was really in response to community stakeholders saying that this is an area of top priority. And that's very much in line, I think, with published literature and what we know from autistic adults themselves. So the research is showing that more than half of autistic adults experience at least one co-occurring psychiatric condition, particularly anxiety, depression, and we're learning more and more about high rates of suicidal thoughts and behaviors. For many autistic adults, these co-occurring psychiatric conditions are a primary source of impairment and a top reason for seeking services. And what I mean by that is if you talk to adults on the spectrum, they'll often say it's not those core characteristics of autism that Lindsay and Caitlin just described so nicely that are really at the top of their list of concerns right now. It's the co-occurring psychiatric piece, the depression, the anxiety, and that's what's motivating them to try to get some type of service, mental health service. Given all of this, it's not surprising that improving autistic adults' mental health has become this top research priority for the autistic community. And again, I think it's really wonderful that Judy and others were able to recognize that need, that priority, and make this conference focus on it. So I do want to spend a little bit of time talking about this general topic of co-occurring psychiatric conditions. And if you were in front of your computer during the break we just had, I think some of my work was already done for me very nicely, describing what anxiety and depression can look like in individuals on the spectrum. What I find really interesting is that co-occurring psychiatric conditions received very little attention in autism research until very recent years. And part of the reason, if you're familiar with our Diagnostic and Statistical Manual of Mental Disorders, or the DSM, previous versions of the DSM specifically precluded certain psychiatric diagnoses in people with pervasive developmental or autism spectrum disorder. So it was basically a rule that you could not, for example, diagnose separation anxiety disorder or ADHD in someone with an autism diagnosis. So of course, this would limit the amount of research that we're doing on co-occurring psychiatric conditions, because those co-occurring diagnoses were just not being made. The DSM-5, our current edition of the DSM, removed these exclusionary criteria, and now there are sections that specifically discuss the high rates of co-occurring psychiatric conditions in autism. So I think that this is a good step forward in terms of raising people's awareness that co-occurring mental health conditions are a big problem for many people on the spectrum. Still, you'll see my second bullet point here. Still have to be careful of diagnostic overshadowing. And that may not be a familiar term to everyone here, so I'll just give a brief overview of that. So the idea behind diagnostic overshadowing is that in many cases, these mental health symptoms are attributed to the diagnosis of autism, and therefore they're overlooked as a distinct disorder. So you can think about someone coming to your clinic and they are feeling really anxious about going to the grocery store. They don't want to leave their house. They don't want to go to school. They don't want to ask teachers for help. They're afraid they're going to look stupid if they ask a question in class. And the clinician says, oh yeah, that's part of autism. So, all right, that's just kind of sweeping it all under that umbrella of the autism diagnosis, and not recognizing, hey, we may have a true anxiety disorder going on here. And as I'm sure you all can imagine, the main reason it's important to identify these separate co-occurring psychiatric conditions is so that we can identify what will be the best treatment, what treatment is needed for those co-occurring conditions. So again, very important to identify which behaviors are here that would respond to a specific treatment. So I'll move through these next few slides somewhat quickly, just because we did see such great information about how co-occurring mental health conditions can present in people on the spectrum during the break. But I think it's important to think about how anxiety could manifest both in similar ways in autistic individuals compared to non-autistic individuals, but also some ways that could be unique or different. So one thing that I've seen a lot in my own clinical practice would be these vague statements. So sure, sometimes you're going to have someone say, I feel anxious, or I'm feeling a lot of worry. And they can describe that anxiety or worry in very clear terms. That makes my job easier as the clinician. But more often I hear these vague statements like, I feel bad, or I have bad feelings. And that's when you have to dig a little bit deeper. Anxiety can make some of those core characteristics of autism more pronounced. So you may see increased inflexibility, increased withdrawal. One thing I think particularly as parents can be really helpful to understand is that sometimes anxiety can manifest in more of those externalizing or outward behaviors like crying, yelling, can look like oppositionality. And it may not be that cookie cutter image we have of anxiety, that, withdrawn, really quiet, scared to talk, maybe more externalizing. There's some really interesting research about unusual phobias or unusual fears for people on the spectrum. So things like the color yellow, men with beards, these types of specific phobia content areas, if you will, that we don't see as often in individuals not on the spectrum. One thing I look for to see, is this an anxiety reaction, or is this some kind of more temporary distress in the moment, is looking for that avoidance, the avoidance of the anxiety-provoking stimulus, and whether there's that anticipatory concern about the situation or about the thing. We talked about hyperactivity, some of those increased repetitive behaviors, verbal perseveration. Again, during the break, we saw that increased need for reassurance, so maybe asking a lot for reassurance or asking for help. Irritability, aggression, and self-injury. So this actually was what led me to kind of expanding my research program to not only anxiety, but also depression and self-harm and suicidality. Was working on my grad school advisor's treatment trial. Dr. Susan White was doing a trial of cognitive behavioral therapy for adolescents on the spectrum with anxiety. And we were really focused on the anxiety, and what was coming up in a concerning amount of percentage of those participants, those adolescents, was self-harm, non-suicidal self-injury, things like self-cutting. So really wanting to pay more attention to those types of concerns. Then I've got one slide here on possible depression manifestations. And again, I think the take-home point here is that there may be some prototypical depressive symptoms, some symptoms that you see in non-autistic individuals, and they look very similar in someone on the spectrum. You also may have things that are more autism-specific symptoms of depressed mood. I think where I see this a lot clinically is when I'm working with someone, they have a focused interest, really intense interest in something, and there's this change from their baseline interest, a loss of pleasure, either participating in that interest, or maybe before they would talk to me a lot about their interest. I could learn a lot about whatever interest they had, and didn't really seem like they want to talk about it anymore. Flatter affect and this loss of pleasure. Similarly, refusal to engage in previously motivating activities. Sometimes that area of focus can shift to something more negative in nature. So if someone is more focused on death and dying or other topics related to death, that would also be something I would want to look more into in terms of whether we could be dealing with a depressive episode. Again, on the break slides, it was good to see decline in self-care, some sort of regression, and then eating, sleep, concentration, weight changes. These are all things in the DSM for a depressive episode, and so these are things that you would want to keep an eye on as well for autistic adults. All right, and then I mentioned suicide a few minutes ago. Again, this is an even newer area of research that's coming out right now, but the studies that are coming out do suggest that autistic adults are at an increased risk of suicidal ideation, suicidal behavior, and suicide attempts than non-autistic adults. In fact, suicide is a leading cause of premature death in autistic individuals. And so this is an area where we definitely need more research and more attention clinically. So when I talk to clinicians about what we should be looking out for in terms of suicide risk, this could be a whole talk in itself. So my apologies for just giving the kind of surface level information here. The big thing and this is really for any psychiatric condition in autism, we're looking for a change from baseline, right? We're looking for, I used to see this individual do X, Y, and Z, or they used to talk about this, they used to enjoy doing that, and then there was this change, and it seems like there's something else going on. That would be a big warning sign that you'd want to pay attention to. Other warning signs: hopelessness, statements about feeling like they have no hope for the future, no reason for living, no sense of purpose in life, withdrawing more from friends, family, or society. I already talked about that loss of interest in typical activities, and the perseveration around death. So there's definitely some overlap here in terms of the warning signs between suicide and depression. Increased rates or intensity of non-suicidal self-injury. There's some emerging research showing that that is also a warning sign in autistic adolescents and adults. And then the last two I have up here are italicized because they are more autism specific, at least in the emerging research, whereas the bullet points above are also listed as warning signs for the general public. If you type in suicide warning signs into Google, you're going to get a list that looks a lot like the first bullet points up here. And then the last two, unmet support needs and camouflaging, have been shown to be unique risk factors for suicidality among autistic adults. Sarah Cassidy from the UK and her research group are doing a lot of work in this area. And in their study on unmet support needs, one thing I'll note about that term was left very broad. So this could be unmet needs in the home, with employment, unmet healthcare needs, including mental health care, unmet social support needs. So very broad. I think we definitely need to dig into that area more to understand what are the specific warning signs or risk factors. And then camouflaging, again, I think we could have an entire presentation and discussion around this. Camouflaging, also called sometimes, more and more is coming out about this phenomenon in autistic individuals where they may try to mask or camouflage their autism in order to try and fit in to social situations. I think we all do this to some degree, and I'm really interested in learning more from autistic adults about their experiences with camouflaging or masking, and how this may lead to increased symptoms of mental health conditions, because frankly it's exhausting, right? It can be very overwhelming to be trying to kind of hide who you are to fit into other people's expectations and things like that. So I will cut myself off there and move on. Like I said, I could talk a lot about that topic, but there are a couple of other areas that I want to make sure that we get to. And when we think about mental health and autism, which we've been thinking about all morning, the lifespan approach is very important, because when autistic adolescents exit high school, they graduate high school and they transition to adulthood, they face something called a services cliff. And what a services cliff means is this sudden and significant drop off in services, including mental health services. And if you're wondering kind of why does that happen, there are a few reasons, I think. One of the main ones is many autistic individuals get most of their supports through the school system, right? They have an IEP, they're getting a range of services through the school system, and when they exit high school, there is no equivalent to an IEP or to a school system structure for autistic adults. And so, very unfortunately, they abruptly lose these school-based supports and services and have a really hard time accessing treatment after high school. To add to the concern, and why I think this is a huge issue that we need to be figuring out, is we know that untreated psychiatric conditions are associated with a host of negative outcomes for autistic people. This includes things like adaptive functioning impairments, difficulties with employment, both finding and keeping a job, difficulties with independent living, social isolation, hopelessness, some of the things we were just talking about as risk factors for suicide, and an overall poor quality of life, which I'm sure is not surprising to anyone listening. So again, I find this very concerning, and I think it leads to this big question of what is getting in the way? What is contributing to this services cliff? And I touched briefly already on the school-based system and the loss of those services, but I want to kind of take a broader view now and just briefly present 4 main problems or 4 main barriers. I know there are more than 4, but we'll stick with that for today's brief presentation. All right, so the first barrier is that many clinicians do not feel confident about working with autistic adults. And when I'm talking about clinicians, I'm really referring to mental health clinicians. That's where most of my work has been focused. However, this same pattern has been found in physicians and medical providers working with adults as well. And even for autism specialists, so people who went to graduate training specifically focused on autism, they may be very well trained in working with children or working on the core autism difficulties. But this idea of treating co-occurring psychiatric conditions in an adult on the spectrum is outside their comfort zone for many individuals. So you've got the generally trained mental health clinicians who don't feel confident, and then you have the autism specialists, many of whom do not feel confident treating mental health conditions in autistic adults. And I'm going to be sharing some quotations with you all from a postdoctoral fellowship study that I completed in Philadelphia. And I interviewed community mental health clinicians, community mental health agency leaders, and autistic adults about this very topic, about how we can improve mental health services for adults on the spectrum. This quotation, I'll read it to you all, is from a community mental health clinician. She said, "I've worked with a lot of diverse populations of all ages, but this is the one area that I would not feel competent to work with." And one area here, to clarify, refers to working with autistic adults. And what I find so striking about this, and I just want to point this out, these are community mental health clinicians who work with clients with complex clinical issues. I have so much respect for these community mental health clinicians. They're working with individuals with active psychosis, with bipolar, with longstanding substance abuse, and they are doing amazing work. They are not confident, though, when it's someone on the spectrum coming into the clinic. And it's very interesting because they treat anxiety and depression every day. It's kind of their bread and butter. But when that anxiety or depression is present in an adult on the spectrum, as shown here, they really do not feel confident. This is a graph just showing, again, this difference in confidence that community mental health clinicians feel when treating anxiety or depression in adult clients. So this is from 100 clinicians, and the take-home message here is that they feel significantly less confident treating anxiety or depression in autistic adult clients compared to adult clients not on the spectrum. My colleague at Penn, Sherry Yeager-Hyman, and I also surveyed 121 community clinicians specifically about intervening with a suicidal autistic client and their confidence there. Surprisingly, only a small subset, 20% of these clinicians said that they would feel confident intervening if they had an autistic client at risk for suicide. So again, lack of confidence across the board. So they're not confident, and this really isn't surprising when we think about how few clinicians are trained to work with autistic adults. So we asked 144 community mental health clinicians hey, have you ever had any training, any education whatsoever specific to autistic adults? And I will say we kept this definition pretty broad. I said, have you ever gone to a workshop? It could be, this kind of 1 hour talk like I'm giving right now. Did you ever have a class in graduate school that talked about autistic adults? Very broad. Even with that broad definition, 83% of community mental health clinicians couldn't remember any sort of training specific to working with autistic adults. Another quotation from a community mental health clinician here, she said, I don't think I would feel that comfortable working with autistic adults because I don't really have the skills. I don't see myself helping that person because of my training. It would be a disservice to that client. And this was a common theme. Clinicians feeling like it would be almost unethical. That word came up a couple of times in our interviews because of their lack of training. They felt like they would be operating kind of outside their scope of clinical practice. Now, of course, this has downstream effects for autistic individuals who are trying to get treatment. This quotation comes from a woman. She said, I can't even find therapists who know very much about autism. So I have to continually be trying to tell them that my needs are not the same. And it's a real challenge to sometimes work with these folks. And I'll tell you a quick story about this woman on the spectrum. She, because she'd had so many experiences, negative experiences with clinicians with very little information about autism, she had started to put together these folders, these packets of information about what autism is, how it can affect a therapeutic relationship, all of whatever she found, an article or something that she thought might be helpful for clinicians to expand their knowledge about autism, she would put it in this packet. And then when she would go to a new, primary care physician or mental health therapist, she would bring that packet of information and give it to the provider. And I will be honest, I have mixed feelings about that story. There's part of me that feels like, wow, that is amazing kind of self-advocacy and being really proactive. And it's really inspiring. And then on the flip side, it makes me really sad because I don't think the burden should be on autistic individuals to be training the professional workforce in the community. And so that story I think will always stick with me. All right, the third barrier I want to highlight here is that even when clinicians have been trained to work with autistic adults, it's not clear what they're trained in. So most mental health evidence-based practices were not designed with autistic people in mind. That's one big issue. And then if we kind of narrow down and look at the evidence-based practices that we have specifically for autistic individuals, many of them are very complex, very multifaceted, and therefore are likely difficult to implement effectively in community settings. So I can give you a very basic example of this. Perhaps the evidence-based treatment manual has 90-minute sessions. That's how the treatment manual is structured. Each session is supposed to be 90 minutes long. Well, most of my community clinician partners can only bill for 50-minute sessions. Doing a 90-minute individual therapy session is just not feasible for their clinical practice. So there's this mismatch. And then I'll end here with a systems level barrier that I hear so much about from stakeholders, and that's this disconnect between the mental health system and the developmental disability system. And this can result in autistic adults being turned away from mental health services. So if you can imagine, pretend that you're an adult on the spectrum, you have really, really bad anxiety, you've really been wanting to get some treatment for your anxiety for a while, but it takes courage to pick up the phone and call a clinic for help. But you do it, you call your local mental health clinic and you say that you need some help with anxiety. You're going through the intake over the phone, they're getting information from you, and then you say, oh, and I also have autism. And oftentimes what we know happens is that autistic adult hears from the person on the other line, oh, well, we don't treat autism here. You need to call the developmental disabilities clinic. Okay, second phone call. Call the developmental disabilities clinic, say, hi, I'm an autistic adult, and I'm calling because I really need some help with anxiety. I'm sure you all could finish this part of the story for me. They often hear on the other side of the phone, oh, well, we don't treat anxiety here. You need to call the mental health clinic. And it's this punting back and forth between these two systems that is extremely discouraging and frustrating when someone is just trying to get the mental health treatment that they need. I think this quotation from an agency leader really summarizes how the lack of clinician training, limited clinician confidence, and this disconnected systems issue that we're dealing with are all interconnected. So this agency leader told me, I think people, meaning clinicians, are afraid to treat people with autism because they don't know what to do. I think if clients have anxiety or depression or schizophrenia, then there's a better roadmap and they feel better trained to do that. They're not trained to deal with people with autism or to manage that. So I think that people are scared to do it. They don't know what to do. So I've been spending a lot of time on the barriers, some of the problems in our mental health for autistic adults, and I'd like to spend the last few minutes of my time talking to some possible solutions. I like to consider myself an optimistic person, so I never want to spend an entire presentation on the negatives, even though there are a lot out there. But let's talk a little bit about the next steps towards improvement. Here's what we need. We need more evidence-based treatments that are adapted or tailored specifically for autistic adults. We need strategies that are feasible to translate to community settings and that are going to be sustainable over time, even when we as the researchers back off, when the study's over and we don't have those resources anymore to give. Will those evidence-based practices continue in the community? We need more training and ongoing supports for community clinicians working with autistic adults. And I think this training, importantly, needs to happen both at the pre-service level, which would mean before they are practicing clinicians, so in graduate school, in graduate programs, through coursework, through practicum placements, and in continuing education, something like this, a continuing education conference. We definitely need coordination between the mental health and developmental disability systems. This is something I think a lot about, and I would love to hear people's thoughts about how we can move forward with this point. We really need to do this so that autistic individuals with co-occurring mental health conditions aren't stuck between these silos of care. And then last, but certainly not least, in fact, I think this is the most important point of my entire talk, is we need to listen to the voices of our autistic partners. They have been telling us, and they continue to tell us loud and clear, that mental health is a top priority for the autistic community, and we need to take action. And so how I'd like to spend my last few minutes is doing just this. I want to share with you directly from some autistic partners of mine their recommendations for clinicians. And I know that not everyone listening is a clinician, but I hope that these recommendations from autistic adults are helpful for a range of individuals. And these quotations really come from during those interviews that I described as part of my postdoctoral study. I told our autistic adults we talked with, I said, I want you to imagine I'm giving a training to clinicians and they want to know how to work better with autistic adults. What do you want them to know? What do you want to be in that training? So these are the 7 recommendations that we heard time and time again from the autistic participants. And I'll show you an example quotation from each one. The first is to use clear and direct language, being very mindful of the language that the clinicians are using. This is a quotation from a young woman on the spectrum She said, one of my favorite sayings is say what you mean and mean what you say, especially with working with people on the spectrum, because we're not going to get the nuances. So if you don't say it, I didn't hear it. So being very direct, while also when, especially when working with autistic adults, being mindful, not to talk down to the individual and not to talk to them like a child, and using that time up front when you're getting to know them to understand what are effective communication strategies for that individual, which is a good segue to recommendation number 2, which is individualized treatment. Recognizing that just like non-autistic people, autistic people bring a range of strengths and challenges, and we need to take an individualized approach in therapy. This quotation says, just know who you're talking to. Know that a lot of people with autism are very smart, and a lot of them have great skills, and a lot of them have great potential. And just figure out how can you specifically tailor to this specific person's needs and interests. And how can you make it relatable and memorable? And what's relatable to him may not be relatable to her, and vice versa. Recommendation number 3, which as a cognitive behavioral therapist, I appreciated this recommendation. And we did not say anything about a specific type of therapeutic approach when we were doing these interviews, but the autistic adults made clear that they really want practical, present-focused therapy, not theoretical discussions or diving kind of back into their childhood. They want concrete examples and very practical strategies for things they can do in their day-to-day life. So this young woman said, I need, as someone who is in their mid-30s, to get my life together. So I really don't want to go through neurotic stuff from my childhood and things like that. If that's important for what's happening right now, then yes. But otherwise, I don't want to sit around talking about that. I want you to talk to me about how I can get a job, how to talk to people, those social skills. The 4th recommendation is to provide structure and predictability. And we talked with a few parents of autistic adults as well, and this is a quotation from a mom, and she was describing how her son very much likes predictability and routine, so he wouldn't really like to go to therapy and then just not know what to expect each time. He'd like to know that this is what the hour is going to look like. So I usually tell clinicians, I know it's not feasible to have the exact same time every, on a certain day, like Thursdays at 3. I know sometimes you can't keep that same schedule every week, but if you can try for your autistic clients, oftentimes that's very appreciated to make that regular appointment time and just making the expectations of therapy clear and making sure that that's talked about in advance. The 5th recommendation is to consider sensory issues. So I know we talked some about this in our first presentation today. I love this idea from one of the autistic men that we talked to. He wants to take a whole bunch of therapists in the same room, have them close their eyes, and imagine being bombarded by sensations that they cannot filter out. Just imagine the stress. You're trying to concentrate on something and somebody's whistling or knocking or doing something like that. So this type of simulation as part of a training for clinicians, I think is a great idea. I know once when I was talking with a clinician about this, she talked about NAMI does a training to simulate having auditory hallucinations that clinicians have gone through, and they said it was such a powerful training. So I love this idea to kind of model something like that, a type of simulation for clinicians to go through. Be comfortable with silence and slow pacing. It seems like for neurotypical people, silence is really uncomfortable and space is really uncomfortable. It's something that people with autism need more of. So just allowing that, whatever it's for, because you need to process the sensory information or you need to process the messages that you're getting. Slow, take it slow, which I will, I recognize that right now I'm not going very slow because I'm trying to wrap up in the last few minutes. So my apologies for picking up the pace a little bit here in the last few minutes. But I think this is such an important recommendation for anyone who's trained to do the ADOS, the Autism Diagnostic Observation Schedule, you are trained to get comfortable with this silence, right? To sit and wait and see if the individual that you're with will have something that they want to say. And just really taking that time to slow it down, and knowing that for some clients you're working with, they may need extra time to process and formulate that response. And then the final recommendation here is autistic adults were clear that they want clinicians to focus on treating the co-occurring condition, right? So this goes back to that disconnect, I think, between the mental health system and the developmental disability system. The adults that I'm talking about, they're not calling and asking for services to treat their core autism characteristics. They want treatment for the co-occurring mental health condition. And many of the adults we've talked with, when they describe their positive mental health therapy experiences, things they really liked, this is what they say. My therapist is really principally just trying to treat the depression and anxiety. He's trying to treat what he can. And so I think that's so important for clinicians to keep in mind. And it really goes back to, what's the presenting problem? What's your client coming in and saying they want help with? Let's go with that. Let's meet them where they are, and know that they are the expert of their own lives. And if they are asking for help with anxiety, then let's focus on the anxiety, for example. All right, so these are my last couple of slides. I did just want to point out that interestingly, many of the recommendations that emerged from these kind of open-ended interviews do map on very nicely with the recommended modifications to cognitive behavioral therapy for autistic individuals across the lifespan. So Judy Reven and many of her team working with Facing Your Fears, these are the modifications that they've incorporated. And it's really interesting to hear directly from autistic adults that these are the types of things that are helpful for them as well. So that was nice to see. I did want to highlight one other resource. I wish we had more time today to talk about suicide risk and suicide prevention in autistic individuals. This is such an important area. And one of my partners, Lisa Morgan, is an autistic woman with lived experience related to suicide loss. And she has developed this amazing crisis support toolkit. And I can drop this link into the chat as well, because I'm not sure if you'll be able to get it just from clicking on the slide, probably not. So I will drop that into the chat. There's both the crisis support toolkit, the first bullet point, and then she also has a website that talks more about this important topic. So I would encourage you to check it out. And this is another great example of listening directly to autistic adults and learning from their experiences. All right, so I'm going to end on this slide here, and I look forward to answering some questions. I love talking about this. I hope that you all found some interesting and helpful tidbits in here. One other takeaway message that I would like to share is, again, thinking about this balance between change and acceptance or appreciation, and trying to talk to autistic adults, really taking the time to listen and understand what are they trying to change in mental health therapy, and focusing in on that. There's so much about autism that we want to appreciate and really lift up. And then there are these co-occurring psychiatric conditions that I think we really need to focus on more. So I am glad that I had this opportunity today to share some of my thoughts about that, and to share some of the quotations from our participants. And I have not been looking at the chat because I knew that I would get distracted. So I haven't seen any of the messages coming through yet, but I know that Judy is going to help summarize some of those questions, and I look forward to having a discussion with you all. So thank you again.
Thank you, Brenna. I'm doing a big applause on behalf of the whole audience. And I can tell that they would be joining me in all this because the chat is exploding in terms of just comments and interest and lived experience and all kinds of things. So thank you so much for all your important work and for giving us a little taste of what you do. So we have about 10 minutes. I'm going to see if I can try to pick a few of the highlights. And Sorry if I can't get, I'll apologize in advance for not getting to all of the really great questions and comments. I'd like to start with a comment or question around ASD and trauma. And I know, again, that could be its whole day long kind of presentation, but I'm just wondering if you can give us a little bit of a taste of what you know about what's happening in the world of ASD and trauma. Yeah.
Absolutely, yeah. So that's such an important area, and I'm not actually sure exactly why, but I feel like when we started focusing a lot more on co-occurring psychiatric conditions in autism, I feel like trauma and PTSD kind of didn't get a fair amount of attention at first. There was a lot of attention on anxiety and depression, I think for good reasons, but and I think a few years ago, people started saying, but what about PTSD? There are all these reasons to suggest that autistic individuals would be at a higher risk of PTSD, but we actually don't have the firm data yet to kind of say one way or the other. I would, again, encourage you to check out Lisa Morgan's site, because she is a trauma-informed peer specialist, and she talks a lot about the role of trauma in her work. Connor Kearns at the University of British Columbia is also doing some really important work in this area related to trauma and autism. So those are two people I would encourage you to check out their work more, because I think where we're finally kind of getting to as a field is recognizing that it's not its own bucket. We shouldn't just be thinking about PTSD. We need to be thinking about how experiences with trauma cut across a lot of these different areas, both of research and clinical practice. So I'm glad that people are thinking about that.
Thanks. Thanks for that answer. I know that you addressed this in your talk, but I guess maybe I'd like to see if you can expand on it a little bit more. And I think there are a lot of people who commented on this. I mean, you clearly talk about the dilemmas in terms of the siloed systems and the lack of trainings and all sorts of stuff. And I guess I'm just curious, separate from some of the stuff that you might have presented, what are you thinking about in terms of how do we increase understanding, awareness of mental health comorbidities or symptoms in our community?
Right. Yes, this is where I think implementation science comes in very, very importantly. So implementation science is an entire field studying how we can move research into practice. And I think we're going to have to be innovative in a lot of ways. One model that I'm excited about, Judy, I know you and I talked about this a little bit, is Project Echo. For anyone who's not familiar with Project Echo, this is I heard something.
It's okay.
This is a tele-mentoring program. It's not telemedicine, and it was not developed specific to autism, but it's a model to connect community clinicians who may, not have that training in some more kind of specialized conditions, connecting community clinicians with the specialists using Zoom, actually. So I got involved with Echo about a year ago. They use Zoom exclusively to connect an expert hub. It's a hub and spokes model, so connecting that expert hub with community clinicians. And that came in handy once COVID hit and everything moved to Zoom. I had a little bit of prior experience with Zoom thanks to Echo. And there's an entire Echo autism movement. The kind of hub there is University of Missouri, but there are institutions all over doing Echo, probably at University of Colorado as well. And I think this is one way where we can, basically we need to spread the knowledge about autism. It can't just be in these specialists' heads. It has to be out there across communities. I think that's a big part of it. I also, I'll just make a quick addition to that. I really think the confidence piece is huge too. I know from talking with community clinicians that, many have misconceptions about autism in their minds. And if we could chip away at those misconceptions, I think it would help them feel more confident to work with autistic individuals. And hopefully that, would be a helpful step forward. And I can give just a brief example to make that kind of more concrete. So many community mental health clinicians I've talked with have said, oh yeah, I mean, I wish I could help autistic adults, but I couldn't do therapy with them. I'm like, why not? Can you tell me a little bit more about that? And they say, oh, well, autistic adults can't talk. And that is their very narrow view of what autism is they're picturing an adult with minimal to no verbal abilities. And that's very outside their clinical practice. And so I think it's also, you know, as part of that education, helping clinicians understand the full spectrum and kind of where their role could be.
Yeah, Brenna, thanks so much for that. I appreciate you talking about both those points. I mean, certainly myth busting has got to be a piece of all of
this. I like that. Yes.
To the confidence issues. I will say one quick thing about the ECHO program, and you're right that that University of Colorado is doing a reasonable amount of ECHO, and in our own department, Dr. Sandy Friedman, Ann Reynolds, and
Great.
Wilson are doing a lot of that work around early identification of ASD. But I like your point, though, in terms of extending it to the comorbidities, because I think that is what we need to be, that's kind of another sort of next step in terms of
yes.
working with folks who already have a diagnosis, but who have other things going on.
We just launched that through University of Missouri. I'm on their expert hub team. We just launched a mental health and autism echo. I know some of my teach colleagues at UNC are doing mental health focused echoes, and they have over 100 clinicians in North Carolina on the wait list. They can't even take them all as part of the echo clinics. So there's definitely a motivation there on part of the clinicians.
Yeah, that sounds great. Maybe we'll talk later about that.
Yes, I love that.
Here's another question for you. Someone talked about having a relative who's an autistic adult who struggles with many issues related to autism and depression and anxiety. And the question is, how can the family of adults or folks in the community assist autistic adults in being able to follow through on what it's required to kind of seek services, access care, be a good self-advocate? Do you have any suggestions for that?
Yes, I think that family involvement can be a big piece. Not for everyone, of course, but for many adults on the spectrum, having that family involvement can help both with access and also with, you know, generalizing some of the skills. What I generally recommend, and again, this would not be perfect fit for everyone, but in terms of the access, I would look for a clinician if this individual is struggling with depression and anxiety, looking for a clinician who's been, you know, really well trained in treating anxiety and depression, and not necessarily that autism expertise piece. That would be ideal if you can find someone in your community with both the autism and the anxiety and depression expertise combined, and they, you know, accept insurance and all of that. Then that's wonderful. But I think if you have to choose, I would generally recommend, you know, trying to find someone that specializes in the co-occurring mental health conditions, and, you know, talking with your family member about how much involvement, you know, they would feel comfortable with, and maybe that's something that you kind of fade over time, but you're there more at first for those sessions. I think, yeah, that's definitely where I would start.
Great, thank you. There's also, I'm just looking at the chat. It's hard for me to keep up with the chat, and I have not been able to do so. But there certainly is a lot of confirmation around including autistic voices in a lot of this work on boards and panels and work groups. So I just wanted to highlight that. Let's see, there was a quick question of where Dr. Kearns is from. That's University of British Columbia. So I think we can answer that one quickly.
Yes.
Let's see if I can find a good quick question. There's a lot of comments about ECHO because it is happening here in Colorado. It's happening in Wyoming.
Well, one thing, I guess, tying those 2 points together, Judy, one thing that we are, I think, finally making some headway on too is I think it's really important to include autistic adults on that expert hub team as well, right? So traditionally in the ECHO model, there's no one with lived experience on that expert hub team. And in the ECHO autism team from University of Missouri, they were the first to add a family advocate. You know, they do a lot of work focused on young children on the spectrum. So they added a family advocate to their expert hub team, which I think was really exciting. And now what we are working toward is including autistic adults on the hub team as part of that conversation. So I'm excited to see ECHO, I think, expand in that way as well for autism.
Right, I would definitely agree. The other thing I'll say about the chat is maybe less about a question and more about neighbors helping neighbors kind of a feel. There's just a lot of really great suggestions that folks are putting in the chat that whether it's hashtags or links, and I know that there had been a request for JFK to pull those off and get them into a document. I don't know how easy it is to do that, but I appreciate all of everyone's efforts to expand the conversation and to contribute to various suggestions. I am looking at our time. It is about a minute after 11. First, I want to thank Brenna again. Applause, applause.
Yeah, thanks for having me.
It was really great to hear from you.